focus on the understanding of the topic. I think next we have Charmaine. Madam will be dealing with posterior segment examination.
So we'll be dealing with the fundus cases next. This comes under your short case category, and in this, you don't get a history, you only get to see the fundus, and fundus drawing is of most important. So before we go to the fundus, what do you need to look at? You need to look at the media clarity. So use your slit lamp and use your indirect ophthalmoscope. The media clarity, if there is any haze, localize where it is, at the cornea, at the lens, at the anterior chamber, or the vitreous. So if it is in the vitreous, you can grade it with your indirect ophthalmoscope according to 0 to 4+. Then after that, we come to the disc. In the disc, madam has already described, you need to mention the size, the shape, the cup size, the NRR, the color, and the isn't rule if it is violated or not. Then the vessels on the disc and exudates and vessels in the peripapillary area. So this is the first case. Can you tell me what this is? You can see there is only a pallor involving the temporal aspect of the disc. So this is a case of temporal pallor. So that would be partial optic atrophy. And this is a totally white disc, pale disc. The margins are well defined. The vessels look normal. So this would be a case of primary optic atrophy. Then we have the margins are blurred. You can see there is a resolving edema there. So this would be secondary optic atrophy. Then we have the classic consecutive optic atrophy. So in optic atrophy cases, you need to know the causes, how to differentiate between each of them, and the field effects that can be associated. So in these cases, most often we do not, the treatment aspects, the newer aspects you have to read up. And in temporal pallor, that is most important because you must not miss that. Then coming to disc edema. Here you have a case of unilateral disc edema in the left eye. It is very slight, but you can see there's a slight blurring of the margins. And in any case of disc edema, think of your 10 signs, which have been described for papilledema. You have the mechanical and the vascular factors, and each of these has to be mentioned in all cases of disc edema. And you will be asked about the Foster-Kennedy syndrome, the pseudo-Foster-Kennedy syndrome, the measurement and grading of RAPD, the field defects involved, and FFA and OCT findings relevant to each of the causes of disc edema, be it unilateral or bilateral. And also, what are the causes of pseudopapilledema and how you will rule them out. So this is a case of bilateral disc edema, the classic. What is this? What do we have here? Bilateral disc edema? Yes, papilledema. So can anyone tell me what the big blind spot syndrome is? Okay, so that is not related to disc edema, it is actually MUDES. Okay. Anyway, then we finished with the disc and come on to the vasculature. Look at the branching pattern, if it is dichotomous or not. Look at the caliber, you mention it as the AV ratio. And if there is any cilioretinal artery is present, you need to mention that separately. Look at the neovascularization if it is present anywhere on the disc, and also differentiate it from collaterals on the disc. So this is a 60-year-old gentleman who has hypertension and dyslipidemia for 5 years, and he comes with a sudden loss of vision for 5 days. So the diagnosis is very apparent. I'm sure all of you know that. The more important thing is the fundus drawing. So you have to know, I thank my JRs for these fundus drawings. They've done a beautiful job. So get your color codes right, and you may also get branch vein occlusions or an old occlusion also as your fundus case. So look for macular edema in the acute situation, and if it's a chronic or an old case, old occlusion, look for NVE, NVD, or any presence of epiretinal membranes, and vitreous hemorrhage if it is present. Then in the other eye, do not forget the other eye. In cases of occlusion, you have to look for hypertensive and diabetic retinopathy, and also glaucoma, because glaucoma is a risk factor for vascular occlusions. Then you have the systemic diseases. These are questions that may come to you, not that you are going to ask these to the patient. So you'll be asked about duration, control, medication, how it affects the vascular occlusion. And if it's a young patient, what all lab investigations you need to do to rule out hypercoagulatory disorders. Treatment options like PRP, anti-VEGF, all these you please read up. Then the 100-day glaucoma and the relevant trials. Then the next case is a 72-year-old gentleman with diabetes, hypertension and CAD. He has sudden profound loss of vision since the morning. There is a grade 1 RIPD and best corrected visual acuity is PL+. Any clues to, any thoughts on your diagnosis? Very good. So this is CRAO here, and we have the classic triad of pallid disc, pallor and cherry red spot with cattle trucking. So in CRAO, you need to know about the causes of cherry red spot and bilateral cherry red spot, especially in the pediatric age group, systemic and ocular risk factors, investigations and treatment options. So this is the fundus drawing of the case. On the right side you have moderate NPDR, you have dot and blot hemorrhages and macular edema there, and on the left side you have the proliferative diabetic retinopathy. So the color coding is important here, and in this again you may be asked about how the duration, the medications control of diabetes helps or worsens the disease. The treatment, if the patient has had any systemic treatment or any other ocular treatment like lasers, anti-VEGF, intravitreal steroids and other comorbidities which can worsen the diabetic retinopathy. And if the pupil is mid-dilated, as some diabetic patients have pupillopathy, you may be able to make out an NVI. So be sure to look at the slit lamp also. And intraocular pressure is important because the patient may have coexistent glaucoma, primary open angle glaucoma or a neovascular component. Then you may be asked about the ETDRS, you will be asked about the ETDRS and the International Clinical Disease Severity Scale. In the DME, you have to grade it according to FFA, according to OCT and landmark studies, the UKPDS, all that, please read up. So differentials in case of a diabetic retinopathy. Diabetic retinopathy is almost a sure case. All of you will have one fundus case as diabetic retinopathy. You can have a hypertensive retinopathy, a vascular occlusion, ocular ischemic syndrome, radiation retinopathy, vasculitis or hematological disorders. All these can come in the differentials for a diabetic retinopathy. So this is a 68-year-old lady, difficulty in reading newspapers and distortion in shape of objects since 2 weeks. So she has diabetes and hypertension and cataract surgery has been done. So her best corrected is 4/60 and 6/18. I heard the diagnosis, you're correct. This is a wet AMD in the right eye and you can see the features of dry AMD in the left eye. So when you are dealing with the case of CNVM, look at the extent, the intraretinal and subretinal heme that is present, document that. If there is any exudate, subretinal fluid, polyps, drusen, anything that is seen, signs of previous inflammation because you may be dealing with a secondary CNVM. And in the other eye, again, if there is AMD, the type of drusen, if there is any geographic atrophy or scarring present, and treatment options, the newer anti-VEGF agents, low vision aids, and also the findings that you get on FFA, ICG, OCT and OCT angio. So this is another 65-year-old lady, loss of vision of 2 months duration, cataract surgery 5 years ago. So one eye has CF and the other is 6/9. So what is this? Yeah, so this is the rhegmatogenous retinal detachment. You need to tell about the type, the extent, location of the tear and hole, any degenerations, any other degenerations present, if the macula is on or off, if there is a PVR present, the grade of the PVR, and PVD, if it is present or absent. On the slit lamp, look at the IOL status, which may indicate a turbulent cataract surgery, any YAG capsulotomy that has been done, and other eye, look for peripheral degenerations, hole, tear, or PVD. So in RD, you need to ask in the history the vision after cataract surgery. If it was good, recurrent redness pain which may indicate a uveitis, YAG procedure, trauma and flashes. Then the other thing is types of RD, the risk factors, ocular and systemic, Linkoff's rule definitely, and treatment options. So this, we'll just go straight to the picture. You can see this is a classic case of retinitis pigmentosa. So you ask for difficulty in night vision, hearing loss, that is you are dealing with a syndromic RP, look at that, family history, and if you can do a pedigree charting, it will get you extra marks. Look for cataract, any myopic refraction, keratoconus, intraocular pressure variations, again glaucoma there, the RP triad, and in the macula, look for edema, atrophy or a epiretinal membrane. So this, what is this? So you may have floaters, you may have vitreous cells close to the retinitis lesion. So this you may pick up on slit lamp, then or the indirect. So look for differences between retinitis and choroiditis, satellite lesions if it presents, any chiaritis, any arteritis that is present, and the DD would include post-fever retinitis, TB chorioretinitis, viral retinitis, and non-infective retinitis as in Behçet. you have to learn about the congenital toxo features and macula scar, why the macula is involved in toxo. So next I invite Dr. Prasanna for her talk.